I'm Spencer King, and we're here to solve a very simple question. Can we eradicate atherosclerosis? On this panel, I have visiting with me today Dr. Renu Virmani, Dr. Steve Nissen, Dr. Seth Martin, and Dr. Peter Libby. And with this auspicious panel, I'm sure we'll solve the problem. Peter, you have done landmark work in describing atherosclerosis. We know a lot about what it is. Can we eradicate it? That's the question. First of all, why don't you give us a little insight into what the nature of the problem is?
Well, the nature of the problem is accumulation in the intima of lipid and cells. It's a combination of a lipid storage disease, but also with a very prominent inflammatory component. And the question is, can we eradicate it? We can prevent it, I think, if we start early enough. But unfortunately, it's too late for us, and it's too late for many of our patients.
So, Steve, when he says too late, you're insinuating that if we got on this problem early enough, we might solve it. Well, how early would you have to get on it?
Well, first of all, I agree completely with Peter. We have to start early. The best evidence comes from the Dallas Heart Study, where if you look at people that have SNPs with a little bit lower LDL, just about 15 to 20% lower, their lifelong risk of atherosclerotic disease goes down by 70–80%. So clearly, starting at birth makes a lot of sense. I'm a little less optimistic than some people because I think this is a polygenic disease, and we only understand a fraction of it. When you look at LDL cholesterol, when we did our studies with IVUS, we can only explain 10 or 20% of the progression rate of the disease based upon LDL alone. So it is polygenic, and we don't even understand all the genes yet. Peter, you've done this great work with CHIP, whole new target. We're going to have to really take on many, many targets in order to eradicate the disease.
Well, before we get into all those targets and how you might do it, I'm surprised that you are not so optimistic, because I thought you were going to say that yes, we can reverse it. You've certainly done observations of trying to treat it and see some imaging changes.
We've reversed a little tiny fraction of the disease. 1 or 2 or 3% of the disease we've been able to reverse. But by the time we are the age of most of us on this panel, we've got a lot of plaque in our coronaries, and that's not going to entirely go away with any of the current therapies we have available to us.
Steph, maybe you can reverse yours. You look to be a bit younger than the rest of us. What's your approach to the patient now to prevent atherosclerosis?
Yeah, I mean, I would emphasize what's being said about the early timing of intervention. We still have a model that's largely reacting late in the process. Plaques are large, calcified, and so on. And so that early timing is the way to go. I think it's a difference, though, as we're discussing, of eradicating, which was the title of our discussion, versus regressing. But the earlier we go, the better chance we have of eradicating or coming close to eradicating atherosclerosis. And I think it's about how aggressive we are. Certainly with LDL, we're now in a time where we're lucky to have a combination of agents. We've been able to move beyond statin therapies to have that. And it's going to be a question of how the timing and how aggressive we are early on. But then, as is being mentioned, it's not only about the cholesterol. There's other factors that may need to be
But our guidelines, you see, unfortunately, are emphasizing the wrong features. They're telling us, well, you have to calculate a certain level of risk, and the big driver in that risk score is age. So it's hard to make young people reach the risk level that the guidelines tell us we ought to treat. And it's paradoxical, because at that point, it probably is too late to do a lot about the disease.
But one thing I'd say is, interestingly, we have certain disease models like familial hypercholesterolemia where we do have a comfort in intervening much earlier in life, where kids who are 8 years old will be started on therapy for familial hypercholesterolemia, but yet in the general population we wouldn't take that. So it's finding sort of taking that early intervention approach and finding the right group of people to do it at beyond disease states like familial hypercholesterolemia.
I was going to ask Renu, because you've looked at more atherosclerosis directly in the eye than the rest of us have, I think.
Yes.
What about this, the histologic, the anatomic difference from the familial hypercholesterolemia? Some children who die, or young people who have it and died of other reasons, and you see this early development. What have you learned that might inform us about how we might prevent it from getting worse?
I think if you look at those early cases, those especially familial hypercholesterolemia, they are inflammatory. That's what Peter has said, shown very nicely, that I think it's a secondary phenomenon. Once the lipid gets here, secondarily you get inflammation. Now the question, why does inflammation come? I think that it's just a matter of removing the lipid. Why it comes there, its function, the cell function, is not to inflame the vessel. The cell function is to take away that lipid. That's why it got there. If there's no lipid, you don't see cells going into that wall.
But there's a paradox here, which is that not all LDL lowering therapies lower inflammation, but some do. And so I'm not sure I fully understand this link between the lipid in the wall and the inflammation that occurs. Is it a chicken or is it the egg that comes first?
No, I think inflammation doesn't come first. If you look at all, and I've looked at quite a bit, we did P-Day study, which was 15 years onwards. And in there, you see the first change that actually is progressive atherosclerosis is when lipid is there. You know, inflammatory cells can come in, macrophages can come in, but they can also leave. It was very nicely documented in animal studies. And as well, if you look at P-Day study, they showed that plaque fatty streaks can regress. And they regress. You may see them at 15 years, but if you go and look later on, 25 years, in the thoracic aorta, it's all gone.
So, Peter, we're talking about different lipid things that drive it, and the relationship, that inflammation that you've done so much important work on. So, we've all heard about Lp(a) and how that's now become an important player. How does that fit into this whole process with inflammation?
Well, Lp(a) is probably, thanks to its homology with plasminogen, more weighting towards the thrombotic aspects of atherosclerosis. And of course, it's genetically very tightly linked to aortic stenosis, which is an epidemic that we are confronting in our elderly population. But there's help on the way, and Steve is just on the threshold of leading a study with an RNA therapeutic that will target Lp(a), and so we're going to get an answer, because I've called it the frustrating final frontier in lipids, because we have had no therapeutic agent that has proven effective in reducing Lp(a) and reducing events. So, Steve?
Yeah.
Tell us a little bit about that study.
Yeah, so by the way, I use the same term, final frontier. Ionis Pharmaceuticals developed an antisense oligonucleotide, a gene silencing approach that involves a single-stranded DNA that is administered subcutaneously and that blocks translation of the message to make ApoA. If you don't make ApoA, you don't make lipoprotein(a). We have already started enrolling patients in a large outcome trial being done at 1,000 sites in 42 countries. And in a few years, we are very optimistic that this final frontier will be one that we can cross and successfully take off the table as a major risk factor.
So I've been excited about that since Sam Samikas told me about this thing. So give us an idea. How long is the trial? How big is it? When could we expect any results?
It's about 8,000 patients. We're going to have a mean exposure of 4 years. It will be monitored very closely by a data monitoring committee. This is a trial that could end early. If it's as effective as we hope it is, then I'll get a call from the DMC a few years from now, and they'll say, time to stop. It's efficacious, but we could have a drug on the market in 5 or 6 years.
So we were talking about eradicating atherosclerosis, but this conversation has shifted completely here because all these patients you're talking about have atherosclerosis. And what you're talking about is preventing events, right?
Yeah, well, but keep in mind, we're doing a secondary prevention trial, but if this works, and we find somebody, this is a genetically determined risk factor, if we find somebody that has, it's 2 standard deviations above the mean for lipoprotein little a, and they're young, then the option will exist in a few years to treat them to prevent the disease, not to try to stop the disease when it's already present.
So we treat kindreds who have, where the proband has high Lp(a) and has events, but I engage in counseling regarding cascade screening, so we can identify kids, teenagers or kids in their 20s who are the offspring of our proband patient, and those are the kinds of people I think we may be able to forestall the development of atherosclerosis.
I have children that I have seen who are the children of parents with high lipoprotein little a that have levels that are 10, 20, 30 times normal. We know what's going to happen to those children if we don't find a way to treat this disorder.
So this would be news to our listeners, news to me, that this new dramatic new frontiers, if you will, could be applied as a preventive therapy.
Early.
Wow, what are you doing now? So with these familial hypercholesterolemia patients that you identified that are not patients yet, they're probands that
You mean the familial high Lp(a).
What are you doing now?
Well, I tried to take care of their traditional risk factors, but I'll tell you something, the anti-PCSK9 therapies will lower the LDL, but what you're left with is enriched in Lp(a), and I actually don't know whether I'm doing people a favor. So it's a feeble, the PCSK9 antibodies are feeble agents for lowering Lp(a), about 15% on that order, but we don't really know if we drive the LDL down to 11, that's going to be all Lp(a) in those particular patients.
They'll get statins now, I guess.
Statins have very little effect on Lp(a).
They actually raise it. They actually raise it about 10%.
But don't they go hand in hand? You also find in the same patients high LDL, and you also find Lp(a).
Yeah.
So it's both of them go together.
Yeah, but part of the reason you're finding that is when you measure LDL, you're also measuring the ApoB containing aspects of the lipoprotein A particles. So it's a little bit complicated to figure out. I do what you do, Peter, is I treat every other risk factor. I counsel these children and their parents that they need to stay thin, they need to exercise regularly, and then at a certain age, this is more controversial, I start them on aspirin.
So there's one aspect.
Certain age you start what?
Aspirin.
Aspirin.
Because we know that it is a very, there is at least some evidence, because of its thrombogenicity, that aspirin may have an efficacious role here.
And since we think thrombosis is driving some of the events associated with Lp(a), but there's a trick to this agent that Steve is leading the trial with an agent that's a second generation or third generation actually antisense oligonucleotide that's targeted for the hepatocyte using a trick. There's a tri-antennary sugar moiety that is attached to the therapeutic that targets it for the asialoglycoprotein receptor on the hepatocyte, which allows a decrease in dose of 15 to 30%. And
30-fold.
And that, 30-fold, right. And we saw terrible injection site reactions with some of the early generation RNA therapeutics. But the injection site reactions in the latest trial were 26%, but most of them were really mild, just erythema.
So are we jumping off the primary inflammatory attack?
No, that's because we haven't talked about triglycerides if we want to be complete about lipid risk. Right. It's triglyceride-rich lipoproteins are a real driver of inflammation, much more potently than LDL. So we have the REDUCE-IT trial, which showed that you can use highly purified icosapentaenoic acid, omega-3 fatty acid, to decrease the triglycerides moderately, 18-20%, but associated with a tremendous benefit, at least in one study. Steve can maybe tell us about a follow-on study that he was leading. But we also have novel generation antisense or RNA therapeutics that can lower some of the components of risk with triglyceride-rich lipoproteins, and novel selective PPAR alpha modulators So that's another frontier that we can attack.
The question really for me is, when do you start these people on these treatments? Do you start at birth? Do you start at 10 years? Do you start at 20 years? When do you start these people?
So, Renu, you confirmed the studies in the Korean casualties, Korean
Yes.
War casualties, and the Vietnam casualties. Maybe you, because you taught me everything I know about Athro,
No, but
maybe you can
disease
remind
starts
us.
early.
I think disease starts earlier. I would say the earlier we start, once the growth period is over, I think 18 years, beyond that, I think we should be very aggressively. Every child that goes into college must have everything done.
That's a great place to start, and a great place we'll have to end because we're running out of time. But this is certainly fascinating. We've gone from a period of trying to get on industrial strength statins, with the guidelines, to now attacking inflammation from various directions, going all the way. PCSK9 was news, seems
Yes.
like last time I sat down at this table, and now we're going antisense oligonucleotides to wipe out our LP(a). It's fascinating. Congratulate all of you, and we look forward to the results of some of these studies. Thanks for visiting with us.
Thank you.
Thank you.